Good afternoon, everybody. I want to thank the organizer of IDCM to giving me this opportunity for this short talk. Almost all of us have been using these antiplatelets. Even general practitioners and even interns get a chance to use antiplatelets quite frequently in the present setup. We all know that platelets have got a physiological function of preventing bleeding, and that is why they cause thrombosis. As long as this prevents bleeding externally, this is great. But sometimes because of breach of the endothelium internally, it can lead to devastating effects like stroke, MI, and so on. So that is where the role of these antiplatelets come. Antiplatelets are those drugs, when they inhibit the platelets, they prevent the function of platelets, that is the thrombogenicity of the platelets. For a proper thrombogenicity to be decreased, at least 50 to 60% of antiplatelets need to be inhibited. So if it is more than 60%, then the chances of bleeding increase. That is obviously the complex side effect, the most important and the more major side effect of it. And if it is less than 55%, it may not help for what it has been given. Hence, the sweet spot hypothesis came, which says that if you are able to achieve this platelet aggregation anywhere between 55 to 70, 60%, you get the optimum result. You are able to justify the use of antiplatelets without increasing the bleeding. The most important drug which we've started using, aspirin. A lot of work had been done on aspirin. We know aspirin is an acetylsalicylic acid. It blocks the cyclooxygenase pathway and thus prevents thromboxane formation, which is again a potent platelet aggregator. So it irreversibly acetylates a serine residue on the cyclooxygenase enzyme, suppressing the production of prostaglandin and thromboxane. Aspirin is a foundation therapy, and when due to aspirin resistance, when we found that aspirin was not effective, the concept of dual antiplatelet agents came, where we use another drug. Aspirin is downrightly used in secondary prevention all the cases. We were using even in primary prevention, but from the past 1 decade, there's a controversy for usage of primary prevention of aspirin. The landmark antithrombotic trial, which almost was, it's a meta-analysis of about 287 studies, where almost more than 2 lakh patients were put on aspirin. It's demonstrated efficacy of aspirin in reducing non-fatal MI, stroke, and even CV death among patients with acute coronary syndrome. So the role of aspirin, as I told, for primary prevention of cardiovascular disease remains controversial. There's an ongoing clinical investigation going on, but since this ASCENT trial came, which was a study done in almost 15,000 patients with diabetes, but with clinically apparent cardiovascular disease, they didn't have any cardiovascular disease. These patients were given aspirin 100 milligram daily. Long back, if you see the older diabetic guideline, they say every diabetic patient should get 81 milligram, but this concept changed now after the ASCENT trial. The reason being, when these patients were given aspirin for a long duration of almost more than 7 years, there was definitely a 12% reduction in serious vascular events, but it also caused a 29% increase in major bleeding. So when aspirin is given in patients who don't have cardiovascular disease, it causes more harm than benefit. Thus, the potential role of aspirin in primary prevention seems confined only to very high-risk patients who have a chance of developing a cardiovascular event in future. Then we come to the second group of drugs. As I told, aspirin created resistance, and then there was a need to have one more molecule. So we found that the P2Y12 receptor antagonists also had a very good, effective, and potent antiplatelet activity. Clopidogrel was the first molecule to be introduced, followed by prasugrel, ticagrelor, and of late we have cangrelor. Now what they do is, they block the P2Y12 receptors and prevent the activation of ADP molecule, thus reducing thrombogenicity. The trial started almost in 2000, early 2000, these trials came. The Capri trial showed that when it was used as a monotherapy, clopidogrel, it caused a 7.9% benefit. But when it was added with aspirin, as a dual antiplatelet agent, the relative risk reduction increased to 20%. Similarly, the CURE trial was also similar. Then the PCI CURE arm also showed benefit after this. Karishma trial was one trial which also tried using clopidogrel as a primary prophylaxis, and it was a negative trial. Hence, just like how aspirin is not used for primary prevention, even clopidogrel should not be used for primary prevention. Now these are the this graph says that when clopidogrel is used for almost 12 months, then it reduced the risk by the MACE events by from 11.5% to 8.5%, almost a 27% relative risk reduction. So when we started using clopidogrel, we used to give a loading dose of 300 milligrams followed by 75 milligram OD. Then later on we found, just like how aspirin developed tolerance, patients on clopidogrel also started developing tolerance. Hence, another trial came where they used a double dose of clopidogrel. Instead of giving 300 milligrams, they gave 600 milligram loading dose and started giving 75 milligram BD once in the morning and the evening. And then they found that when a double dose was given, there was another overall extra 15% relative risk reduction without increasing the mortality. And hence, we found that double dose of clopidogrel is definitely better. And as we use a double dose, we have a better antiplatelet effect. Definitely that translated into reduced stent thrombosis. The stent thrombosis reduced by 42% when clopidogrel was used BD. Many times you may be seeing that these patients who undergo recent angioplasties, they come with a BD dose. Usually up to 30 days, it does help by reducing the stent thrombosis. But after 30 days, since the stent gets endothelialized, there is no need to have such a strong potent dose of clopidogrel, then you can make it OD. So for first 1 month, if at all a patient is on clopidogrel, your cardiologist may prefer to give BD dosage, and then after a month, it comes down to OD dose. Now, antiplatelets are not only used for this, even for stroke, antiplatelets are used very commonly. So, initially a dual antiplatelet drug was used even for secondary prophylaxis of stroke. But then they found that when clopidogrel was added, it increased the bleeding of patients. And this CHANCE trial and the POINT trial showed that addition of clopidogrel to aspirin in non-disabling stroke, and it found reduction in stroke progression or recurrence, but at a cost of increased bleeding. Hence, DAPT, if at all, has to be used in patients with TI or new stroke, it has to be used only for a matter of 30 days to 3 months. You shouldn't prolong usage of it, and then it's always better to keep these patients on a single antiplatelet agent like aspirin. Because of this clopidogrel effect, it would take a long time to act, and clopidogrel resistance, a new drug came, prasugrel came. It is similar to clopidogrel, but it is very fast acting, it is more potent, but it is to be used only in those subset of patients who undergo an angioplasty, who get a stent. And in elderly patients, it's not to be used, and patients with a history of stroke, it's contraindicated. And this prasugrel molecule came to us from the evidence of Triton-TIMI 38 trial. It showed that when clopidogrel was used, it gave a further reduction by 9.9% even compared to clopidogrel, thus reducing a 19% relative risk reduction with prasugrel over and above that of what we were getting with clopidogrel. But on the same side, it increased bleeding. Prasugrel caused bleeding incidence of 2.4% compared to clopidogrel. And as expected, the stent thrombosis goes down. Ever since the advent of prasugrel came, stent thrombosis is actually very rare among the cath labs now. Very rarely we get patients with a stent thrombolysis because we've got very potent antiplatelet agents now. Ticagrelol. This is also used along with aspirin as a DAPT. The evidence came from the Plateau trial. Normally we know that we give it as 90 milligram 2 tablets loading and followed by 90 milligram BD. This came from the Plateau trial. It can be used up to a year as a dual antiplatelet, but if you are worried about the higher dosage of such a strong potent, you can even use 60 milligram BD, and this evidence came from the Pegasus-TIMI 54 trial. If you see this graph, whenever you give ticagrelol, within half an hour, almost we have achieved almost 60% of antiplatelet effect. Whereas when we use clopidogrel, to achieve a 50-60%, it takes almost a matter of 4 to 8 hours. So if you load a patient with clopidogrel and send him to the cath lab, the cardiologist would have finished his angioplasty within half an hour, patient would come back to the ICU, and unfortunately our clopidogrel has still started not acting. And then the chances of stent thrombosis can happen, the patient may develop a reinfarction in the ICU and you may have to shift back. But if the same thing is given with ticagrelol, then you are sure that by the time the cardiologist puts a stent, we have achieved an antiplatelet effect in the blood of a platelet inhibition of more than 50%. Prasugrel also does the same thing, but in case if the patient is not going to be stented, then you will have to again shift back the patient from prasugrel to clopidogrel. But with ticagrelol, you can continue using it even in patients who have not undergone any intervention. Another important side effect I wanted to highlight about ticagrelol is 15% of these patients may end up having breathlessness. Breathlessness usually is a side effect of this ticagrelol, but it disappears over a period of time. If you continue using it, the patient gets used to it and then he doesn't complain of dyspnea further. But before labeling it or blaming ticagrelol for dyspnea, especially after a patient has undergone angioplasty, you should always do an echo and at least confirm that there is no new complication like a new onset MR or the EF has gone down because of remodeling, because then if you continue and if you don't treat heart failure, that can be detrimental to the patient. What if a patient is unconscious or patient is repeatedly vomiting after an MI? It usually happens in inferior wall MI. Patients keep repeatedly vomiting. In such conditions, any oral medication is not going to be of help. We have a new molecule from the Champion trial called the cangrelol. It can be given IV. The benefit of it is it starts acting within 2 minutes after you give IV. And when you stop the infusion within 3 to 6 minutes, it's reversible. So it can be used, and let's assume that after the angiography there's a critical TVD and the patient wants a CABG immediately, then you can safely get the CABG done the very next day because the effect of cangrelol goes away. Newer antiplatelet agents are on the block, like the protease activated receptor, Vorapaxar. It acts over here. And then we have more experimental drugs in line, like the phosphatidylinositol 3 kinase inhibitor, protein disulfide isomerase inhibitor, PAR4 antagonists, and even the lipoxygenase inhibitors are also showing some antiplatelet action now. Now let me come to the second part of it, anticoagulants. Warfarin and acinocoramrol, we know that these are the vitamin K dependent antagonists which are used time and again from a very long time. These drugs have been used very frequently as an anticoagulant. But apart from that, now we have direct thrombin inhibitors, that is a direct oral anticoagulants, which are also used. So now warfarin and acinocoramrol, they affect the factor 7, factor 9 and factor 10, and the remaining all thrombin inhibitors, remaining of the coagulation cascade is affected by the thrombin inhibitors. Warfarin and acitrom almost are at par. You can interchangeably use them. The only benefit of using acitrom is in case if you don't want to give a high dose, sometimes patients may require almost up to 10 milligrams of warfarin. Almost they are going towards the stage of resistance to warfarin. In such a situation, you can go for acitrom, because acitrom, 60% of warfarin dose is enough by acitrom because the potency is almost 160% with acitrom. Or else more or less both are the same and you can interchangeably use them. Now the use of vitamin K antagonists in modern era has just been left to only two conditions. One is a structurally abnormal heart like rheumatic heart disease, mitral stenosis with AF, or a patient who has undergone a prosthetic metal valve post MVR, post surgery. In atrial fibrillation, anticoagulation is very commonly used because of the risk of thromboembolism. Whenever the risk, almost 15% of strokes at any age are attributed to atrial fibrillation, and almost 60% of strokes after the age of 60 are attributable to thromboembolic phenomena due to AF. This can be detected, you can detect the risk of a patient having stroke by the CHAD score, like congestive heart failure, hypertension, age, diabetes, previous history of stroke. You give 1 point to each, and if there are more than 2 points, that means there's a chance of more than 2% per year that the patient can develop stroke. In such a situation, then it becomes mandatory for us to put these patients on anticoagulation to prevent stroke. But again, as anticoagulants can increase the bleeding, you can even assess the chance of bleeding by the Hasbled score. Now, these newer anticoagulants, endoxaban, it showed benefit by the ENGAGE trial. The apixaban was used in Aristotle trial and it showed benefit, and the Rocket AF used rivaroxaban. All these trials gave a relative risk reduction from 19 to 25% all across the spectrum in reduction of stroke. Now, how do we decide? As I told you, the Markov decision model is used to define whether the use of anticoagulation, whether you want to risk using anticoagulation to prevent stroke. All the trials showed that when the risk of stroke was 1.7% per year, then it is safe to use warfarin because it outweighs the risk of bleeding, because the chances of stroke is more now, it is almost 2%. And with newer oral anticoagulants, the risk of bleeding is very less. So here you can be more liberal in using. So with direct oral anticoagulants who have a better safety record in terms of bleeding, even a 1% risk of stroke per year also makes sense to use these drugs like dabigatran or apixaban to prevent stroke. A question which may be coming up in your mind is, when antiplatelets can be used, why can't we use for secondary prevention of clot formation, why can't we use the same thing for atrial fibrillation? Why do we subject our elderly patients with such a strong anticoagulant drug like warfarin to prevent stroke? Now I'm going to quote some few trials which are going to say that it is not going to be helpful to prevent stroke. So if we have a patient, let's say 60-year-old male with AF, is it okay to use just aspirin or clopidogrel? No, the Everest trial showed that when aspirin was pitched against vitamin K antagonist in AF, it was seen that warfarin was better compared to aspirin in preventing stroke. The SPARF trials, all the 3 trials, trial 1, 2, 3, aspirin did not show reduction of stroke incidence. The Japan trial did not show benefit with aspirin. The active trial, where people said only using aspirin may not be helpful, let's use dual antiplatelet, let's add clopidogrel to it. Even this trial said that in spite of using dual antiplatelet drug, warfarin was better in preventing stroke in AF. Hence, antiplatelets are not indicated in patients with AF unless they have associated coronary artery disease or have undergone a angioplasty. Certain scenarios where we may again be in a very dilemma how to use this anticoagulants, especially pregnant ladies. If they have AF, what do we do? Direct oral acting coagulants like dabigatran, apixaban and rivaroxaban are contraindicated because we don't know much about these drugs. They may be having a teratogenic effect. But vitamin K antagonists have been used from a very long time. It can be used. If we are using less than 5 milligram, it can even be used in the first trimester, but it is safe not to use in the first trimester. It is always better to give low molecular weight patients to these patients and then switch back to heparin in the last week of pregnancy. Another scenario, maybe this is going to be my last slide. Since the risk of stent thrombosis is high, suppose if a patient has got atrial fibrillation and has already undergone a stent, what do we do? Do we remove the dual antiplatelet drugs? No, it is better to use all the 3 drugs at least for a month after the acute event of MI, albeit at a very low risk of a slight increased bleed. But after 1 month, remove aspirin from that, and instead of having a triple drug, use only clopidogrel along with dabigatran or apixaban. Aspirin has been removed because aspirin can cause gastric erosion and major bleeds, GI bleeds. In chronic stable angina, a large meta-analysis showed single monotherapy with rivaroxaban was also effective in this. The other place where we use anticoagulants is DVT. I would not be going into details of this in view of time shortage. Thank you.